Hi guys, in this video we'll be discussing about the circulatory disorders of the liver. And in this video there's gonna be a list of circulatory disorders, the etiology and pathogenesis for them, and the relevant pathological and clinical findings. So the list of circulatory disorders within the liver. Before we get into that, we should do a small recap of anatomy. And the main thing you gotta remember from anatomy is that the liver has a dual blood supply. It receives blood from both the hepatic arteries and from the portal vein. And that's why even if there is a compromise in one of them, as long as the other one is not severely compromised, the liver can sustain its function. Now, this is a big if. It depends on the individual circumstances, but generally, if one of them is working fine and the other one is slightly compromised, the liver will not be affected to a very high degree. However, it depends. Now, it depends. The pathologies are categorized depending on where they arise. So it could be the inflow impairments or prehepatic. So, and it can include the hepatic arteries and the portal vein. It can be intrahepatic, involves circulation within the liver, and it can be regarding outflow impairment post-hepatic, involving the systemic venous return, which will include both the hepatic vein and it drains into the inferior vena cava. So the inferior vena cava as well. Now, talking about inflow impairment, as we mentioned earlier, it involves both the arterial and the portal vein, so hepatic arteries and or the portal vein. So if there is a problem in the hepatic artery, it will cause decreased perfusion to the liver. Common etiologies include thrombosis, emboli, mass obstructions, and polyarteritis nodosa. Polyarteritis nodosa is one of the medium vessel vasculitis, and you can know more about that in the blood vessel pathology section. Uh, Mass obstruction basically means that if there is any tumor growing, the growth of the tumor can compress against these blood vessels, such as the hepatic artery, and compression against the vessel will obviously reduce the cross-sectional area of the vessel, hence decreasing the perfusion and flow rate. What happens there is that it leads to ischemic necrosis of the liver. Over time, adaptation is by atrophy and cirrhosis. So, decreased blood supply, decreased perfusion of nutrients and oxygen, uh, the cells can become ischemic, then leads to necrosis, they can die. And then healing is by regeneration, and cirrhosis is also regeneration nodules and bands of fibrosis is cirrhosis. Macroscopically, you see an atrophied cirrhotic liver, may be slightly gray depending on the extent of cirrhosis. And this this what I mentioned just right now is a late chronic finding. However, if you have the autopsy of a person who died immediately of this issue, then you would see a hemorrhagic infarction within the liver. So it's going to be reddish because of the blood accumulation. It's hemorrhagic infarction because it's dual supply once again. So even the hepatic artery is blocked, but the blood still flows in from the portal vein. So obstruction of the portal vein, any etiology again. So in similar ones, thrombosis, emboli, mass obstructions. It leads to prehepatic portal hypertension. So portal hypertension is classified into prehepatic, intrahepatic, and posthepatic variants. So if you have any issues with the portal vein, it will lead to prehepatic portal hypertension. Macroscopically, you will see a pseudo infarct of Zahn, that's the term, and it basically is atrophy without any necrosis, with blue and red discoloration of the liver. Now, for intrahepatic impairment, this would basically involve all the vessels within the liver and basically compromised blood flow within the liver. Etiologies are basically cirrhosis, sickle cell disease, disseminated intravascular coagulation, and hepatic veno-occlusive disease. Now, what happens in cirrhosis? That's the most common cause. Uh, so what you have is fibrosis of the sinusoids within the liver, and since they're fibrotic, the blood flow is going to be compromised. So it's going to decrease the flow from normal to these hepatocytes, and that leads to ischemia and then necrosis. So the hepatocytes can die. And sickle cell disease, because of the distorted shape of the red blood cells, they can basically get stuck in the sinusoids, or they can occlude the blood flow within the sinusoids by obstructing the vessel. And then in DIC, basically you have multiple small thromboses within the liver, which again obstruct the blood flow. And hepatic veno-occlusive disease is basically endothelial injury within the sinusoids due to chemotherapy or radiation. And again, all of these etiologies in the end lead to obstruction of the hepatic sinusoids, then decreased blood flow, necrosis, and then again cirrhosis over time, apart from cirrhosis, obviously. And this leads to intrahepatic portal hypertension. And the morphology would be diffuse necrosis of the liver. Over time, it leads to cirrhosis and liver failure, given that the main etiology is not cirrhosis itself. Then moving on to outflow impairment. So this is considered within post-hepatic portal hypertension. And then it could be either the hepatic vein or the systemic circulation, basically the inferior vena cava, right atrium, etc., as mentioned earlier. Now, if it affects the hepatic vein, it's termed as Budd-Chiari syndrome. When you have obstruction of two or more major hepatic vein branches and give rise to post-hepatic portal hypertension. The etiologies or the etiology mainly for Budd-Chiari syndrome is if you have any hypercoagulable states or you have a compression by a mass of the hepatic vein. And for hypercoagulable states, it's mainly polycythemia vera, in which you have an increased hematocrit because of increased RBCs. Uh, Now, hepatosplenomegaly, jaundice, ascites, esophageal varices, caput marusa, these are the main findings you see. Now, why do we see hepatosplenomegaly? Now, starting off is we're going to discuss why we see hepatomegaly. It's because once the blood flow is obstructed through the hepatic vein, it's going to start backing up within the liver. And when it backs up into the liver, it's going to dilate the sinusoids, uh, and that's going to give the liver, stretch the liver out. That's why it's going to be hepatomegaly. Splenomegaly, when you have impaired flow from the hepatic vein, this will give rise to shunts. The blood will start shunting to find a way to the right atrium from uh, other pathways. And one of the main pathways over here is through the splenic vein. So the blood mainly shunts to the splenic vein, increasing the flow into the spleen, giving rise to splenomegaly. That's splenomegaly. Then you also have jaundice because of the liver, damage to the liver, give rise to hepatic uh, jaundice. Ascites, again, because liver damage low protein production, especially albumin, or the other case is that there's lack of like the blood starts accumulating, so there's congestion, and then congestion causes there to be more time for fluid flow exchange to occur. Esophageal varices, again, because of shunting, these are quite dangerous. Esophageal varices, they can rupture because the veins around the esophagus are quite uh, weak relatively. That's why if there is a increased blood volume in them, it can lead to their rupture. Now, that's a complication, rupture of esophageal varices. Then caput medusae is basically again shunting of the blood, but this time it uses the superficial venous system in the abdomen. And there's a picture, I think, on the next slide. So etiology is again mass obstruction, hypercoagulable states such as polycythemia vera. You also can see macroscopically nutmeg liver. This is an important term for you guys to know. It can be asked, it definitely will be asked. Basically, because of the venous congestion in the liver, it leads to hypoxia. And prolonged hypoxia leads to centrilobular necrosis. And then steatosis occurs, sinusite dilation leading to nutmeg liver. So these all occur in steps. Hypoxia obviously reduce oxygen. Reduced oxygen will lead to necrosis, and one of the first changes of the liver or first responses of the liver is steatosis, basically. That's why you see steatosis, sinusite dilation because of this congestion, and it leads to a nutmeg liver. And I think I also have a picture of this on the next slide. Now, if there's compromise in the systemic circulation, what happens is the etiology is mainly due to right side heart failure. Uh, Again, blood starts pooling back into the previous vein. So that this time it's the entirety of the systemic circulation, venous circulation. So again, similarly as hepatic vein obstruction, the same clinical findings are seen. Post-hepatic portal hypertension, hepatosplenomegaly, jaundice, ascites, esophageal varices, and caput medusae, and nutmeg liver. Here is a picture of nutmeg liver. This is how it looks like. You can see these red spots are dilated sinusoids, and these yellow areas represent uh, steatosis, fatty change in the liver because of injury. Here it is. This is caput medusae. This is how they look like. You can see these are all dilated abdominal veins, superficial venous system in the abdomen because of the increased blood volume in them. So this is actually like a more severe case of them. And here you see ascites is basically accumulation of fluid in the peritoneum. That's it for this question. Just know the divisions into pre, intra, and post hepatic and complications. And in this question, it's more important that guys should know the clinical manifestations, such as the ascites, food medusae, varices, etc., and their complications such as esophageal varices can rupture. And that's it. Thank you.